Yes, it looks great.
Okay, thanks. Thank you for letting me spend a little while with you today going over some ideas for patient materials and resources for your fracture liaison service program. I'm going to give you lots and lots of information in this short period of time, but all the information I'm going to talk about today is going to be on the National Bone Health Alliance website, which is the nbha.org site. I'll carefully walk you through how to go to their site and access the tools step by step at the end of this presentation. We will also have time for questions at the end, and I will give you my email address and phone number if you'd like to contact me at a later time. I'd really like to suggest to you that you learn from the many years of combined experience of those that have already started FLS programs and encourage you not to try to reinvent the wheel. The NBHA site has a wealth of information for you. FLS programs have been figured out for you already, and all of their information, and I mean many FLS programs, are on their site. You just need to find out what will work in your organization. Today, I'd also like to briefly describe our Healthy Bones program as an example of a fracture liaison service. Now, with this slide in front of you, I know I'm preaching to the choir when I show this slide, and I won't spend a lot of time here, but I just want to show you the huge problem that we have with osteoporosis. Even though we have had osteoporosis awareness for a long time now, and we've proven that there's fracture reduction benefits with several osteoporosis medications, it's amazing that less than 1/4 of patients age 65 and older who break a bone, receive such care. FLS has been developed in many health systems, but has not been widely implemented in the United States. And this just continues to amaze me. Here we see a few actual pictures of the face of osteoporosis. I have severe osteoporosis in my family, and I was actually just sharing a story with Debbie. Many of my family members have become kyphotic. They've lost height. They're using walkers. They have many broken bones, which have resulted in hospital admissions and nursing home stays, just like the ones in these photos. So osteoporosis is very near and dear to my heart. It's very much a personal passion for me. When we first started our FLS in about the year 2004, 2005, we had problems like everyone else. Our hip fractures were costing our organization a lot of money. We realized that our patients were not getting treatment for osteoporosis after having a fragility fracture, and this was actually a nationwide problem, and unfortunately still is in many cases nationwide. There was no consistency among our medical centers, so we have about 14 medical centers, and each one had a different way of running the program, so there wasn't consistency. When we looked at coding is a big issue. When we looked at that and we ran our numbers, we were shocked to find out how much money was being left on the table each year. And we were performing poorly when we compared our organization to other organizations in regards to the HEDIS measure. But our program proved to be successful. By the year 2012, we ran some numbers and we found that we were able to reduce our hip fracture rate by about 50% lower than expected. So that meant that we saved about 1,587 hip fractures and 387 lives. We saved about $52 million, and these were hip fracture costs, and about $7 million in revenue. And we were first in the nation in our HEDIS measure. This was huge for us. So we try to keep it very simple. We order DEXAs preventatively on our women age 65 and older and our men age 70 and older on all our fracture patients except for fractures of fingers, toes, face, or skull, no matter what the reason for the fracture. When we first started, we were ordering them just on fragility fractures, but now we order them on all fractures. age 50 and older, both men and women, and on those patients who have been on bisphosphonates 5 years and longer. We start medication on those that need it, we monitor adherence, and we evaluate at 5 years or longer. We try as often as we can to utilize as much of our support staff as we can from the departments our programs may be housed in. Since our program itself does not have a lot of support staff, such as administrative assistants, and we try to utilize our volunteer staff whenever possible. Again, I'd like to suggest to you to not try and reinvent the wheel. You just need to find what will work in your organization. Once again, I'm going to stress that there are a lot of FLS programs. There's a lot of work that's already been done for you. We also built to the current HEDIS measure that was in effect at the time we started, which was very important when we started. We wanted to minimize patient handoffs, return visits, especially for those elderly patients who have transportation issues. Often it's daughter-in-law, son who's bringing mom or dad for their visit. They need to get back to work. They need to pick up their kids. So there's always transportation issues for those older patients. We wanted to limit the impact on our primary care providers. So by using mid-level providers such as nurse practitioners and physician's assistants, we were able to take it out of the hands of the primary care providers, but still keep them in the loop if they wanted to stay informed. The main advantage of using mid-level providers is that they can diagnose and treat and document and code. Now, that doesn't mean that you can't do this without a nurse practitioner or a physician's assistant. I'm a nurse, but I'm not a nurse practitioner. And when I first started, we used a nurse protocol. I was housed in an orthopedic department, and I was just constantly chasing the orthopedic surgeons for signatures for Fosamax. Now, mind you, that was back in the day before we had electronic medical records. So I was literally with a paper chart running around chasing people for a signature on a piece of paper. Now, some areas currently in our medical centers use virtual visits. You're probably noticing a lot of your meetings are webinars or they're teleconferences. We actually use virtual visits for some of our patient visits. And we call the patient after they've had a DEXA scan if they're not able to stay and see our Healthy Bones Care Manager. So there are many ways to have an FLS program. We have a centralized workflow used by our Healthy Bones Care Managers, and these are our nurse practitioners and physician's assistants. Our workflow is important so that we have standardized care across all of our medical centers. We make sure that we have clear workflows with detailed accountabilities. It's really important for there to be a centralized team of players to own the program. And this one I'm going to repeat again. It's really important for there to be a centralized team of players to own the program. Without people taking responsibility and being accountable for these patients of your program just won't work as well. Like I mentioned earlier, we utilize as much support staff as possible, even volunteers. So a volunteer may be the one to walk the patient from, say, as an example, an orthopedic department to the DEXA scan machine, or maybe they can just stuff envelopes for you. We actually try to also incorporate this, what we call a just-in-time idea, into every workflow we have. So this is a concept that we call a one-stop shop, where everything can be done after the DEXA scan all at one time. As an example, when a patient has, let's say, an orthopedic appointment, and we notice they need a DEXA scan, we can say to them, let's get your DEXA scan today. And if possible, we walk them over to the DEXA scan machine. So if they feel that this DEXA scan is part of their appointment, they're more likely to stay and have it completed. Or if a woman is having her mammogram and it's noted she needs the DEXA scan, it's offered to be done during that same appointment, and then there's no extra cost for her. So let me take a minute and walk you through our workflow. A patient has a DEXA scan. Almost all of our DEXA scan machines are housed near where the Healthy Bones care manager sits, so it's very convenient. The patient walks over to the Healthy Bones care manager immediately after they have the DEXA scan. The Healthy Bones care manager then reviews the DEXA results with the patient. They're given some education about osteoporosis, calcium, vitamin D, exercise, fall safety. Then medication is ordered if needed, and also the labs. Then we have our pharmacy, the lab where the blood is drawn. Everything is right there in the same building. Then we have osteoporosis classes that the patient is referred to. The Healthy Bones care manager then documents and codes in the electronic medical records for this patient, and then the primary care provider is kept in the loop through the electronic medical records. In our SNFs, nursing facilities, the geriatricians and the nurse practitioners and physician's assistants are responsible for this process. We also utilize both in-reach and outreach to our members, which is supported by our electronic medical records. But if you don't have electronic medical records, it can also take the form of a letter or a phone call or an automated phone message. We also have many standardized pieces of education for both our primary care providers and members, and I'll discuss those with you this morning. Or it's afternoon for you. Sorry, I'm in California. They can easily be used as a template for you to create your own individualized pieces. So let's take a look at some of our tools for success, and hopefully that will give you some ideas. The NBHA has so much information on their website, and once again, I'll walk you through how to access these tools today. We try to keep our providers well educated about all of the current issues having to do with osteoporosis awareness. On the screen in front of you is an example of one document that we created that listed many of the common facts, figures, and statistics that would be frequently quoted about osteoporosis and fractures. We had many requests saying, oh, we hear that half the women after the age of 50 will break a bone. Where did that figure come from? So we finally created a document for our providers. There's also a sample of an ISCD, and that's the International Society of Clinical Densitometry training that was provided for our primary care providers. Our nurse practitioners and physician's assistants are all ISCD certified. We create brochures and posters for lectures and health fairs. The one on this slide explains our Healthy Bones model of care and has a matching poster, which is a nice display for a conference a provider may be attending. We provide three main sets of working guidelines. We have our Kaiser Permanente clinical practice guidelines, the Kaiser Permanente national guidelines, and then we have our own Healthy Bones care manager guidelines. And these are the ones that we tailor especially for our nurse practitioners and physician's assistants. We provide what we call our FAQ sheets, and these are answers to frequently asked questions, FAQ, frequently asked questions, about individual topics, usually whatever is a current popular topic, say atypical femur fractures as an example, or ONJ, osteonecrosis of the jaw. At one point, we created a clinician FAQ for DEXA Z scores when we realized that many of our primary care providers were not familiar with the specifics of the Z score on the DEXA scan report. We had many questions about what the Z score was. So we created an FAQ for our primary care providers. We also provide job aids, which are step-by-step guides for carrying out a process that would possibly be part of our workflow. As an example on the screen, you'll see a FRAX decision tree. Many of our job aids are in the form of decision trees or workflows. So it's very easy for our providers or our Healthy Bones care managers to carry out step by step a process of the workflow. As I mentioned earlier, we use every opportunity and every point of service to outreach to patients. Even if you don't have electronic medical records yet, we have opportunities with letters, phone calls, automated phone messages that you might be able to look at. We also encourage May, which is Osteoporosis Awareness Month, as a time to increase awareness at our medical centers. In October, there's one day that's National Osteoporosis Day. That's also a good time to increase osteoporosis awareness at your institution. And we send out ideas, and usually we have one day or 1 week in May when we try to all participate in an osteoporosis awareness event together. The more osteoporosis awareness you can encourage at your institution or your hospital, the more people are aware of osteoporosis, the better that will be for your patients. We provide many education handouts and a customized booklet from Crames covering many education topics such as calcium, vitamin D, fall safety, how to have healthier bones, just as examples you see on the screen. Similar to our provider frequently asked questions about current topics that I mentioned a few slides back, we also provide the same for our patients, for our members. So usually when we create one for our primary care providers, we will create a matching similar one for our patients. We found that having consistent member communications coming from each of our programs at each of our medical centers is most effective. As a result, we've created, as an example, standard patient letter templates for the Healthy Bones care managers and primary care providers to send to their patients. We also have what we call after visit summaries that will match the letters which are given to the patients. And this is a piece of paper, and after their visit, they take this home and they have time to review it at home. It's also available for the patient online. But oftentimes the older patients don't have the availability to go online, so having it available as a piece of paper that they can read is convenient. What's nice about the letters is that they're very simple, they're easy to understand is what you want for general member comprehension. They've also been approved from a legal standpoint. For our automated phone message system, we've created scripts for recording. One of our latest phone message recordings, as an example, is for patients who have not picked up medication. So these might be things you'll be interested in looking at. We also have this great set of bones, which are an excellent way to actually show patients what their bones feel like normally, and then what they feel like if they have bone loss. So one bone actually weighs heavier than the other, and when the patient picks them up, they're always really impressed. So they hold one bone and it's heavier, and then they hold the other bone and it's lighter, and this is how they tell what their bones feel like when they have osteoporosis. So the ordering information is posted for you on the NBHA website if you're interested in purchasing a set, and there's even a discount price offered for you. We found much success using decision aids with patients. The ones we use come from a talk given by Dr. Michael Lewicki, who's well known in the field of osteoporosis. The care manager or the primary care provider is able to use this as a visual aid to help the patient make a more informed choice about whether or not to take medication. This is especially helpful if you use shared decision making. And here's some, these on the screen are two examples of decision aids. Here are two more examples of what decision aids look like. And I'll give you an example of how a decision aid could be used with your patient. So if you look at the seatbelt decision aid, you could possibly ask your patient, would you ever drive without wearing a seatbelt? And then show them the decision aid with the seatbelt. And show them that the seatbelt reduces the risk of serious injury and death by 50%. Treatment with bisphosphonates, like the seatbelt, reduce the risk of fractures by 50%. I usually share a story of my husband who had an accident with the seatbelt on. His truck flipped completely upside down. He was literally hanging from the seatbelt. He walked away with only a small bruise from where the seatbelt pulled on his shoulder when he was hanging upside down. But the seatbelt kept him from having a serious head injury or possibly being killed. The same, I tell the patient, is true with the bisphosphonate medication. Even though there's a small risk, very, very small risk, and they can see that from the decision aid, of a side effect, such as an atypical femur fracture or O&J, it can help prevent a hip fracture in the event of a fall or even untimely death. Excuse me. So why do we use all these tools and resources? At Kaiser, each hip fracture costs us about between $35,000 and $40,000. We save one hip fracture for every 100 patients treated. If you only look at the economics, our saving one hip fracture for every 100 patients treated is a lot of money saved. We save about one life for every 25 hip fractures avoided. This is priceless. And to be able to preserve member independence is also priceless. My own mother has severe osteoporosis. She's fallen more times than I can begin to tell you. She's broken bones. She's in one of our Healthy Bones programs. And even though she hasn't always been compliant with her meds or vitamin D through the years, we've managed to keep her from breaking her hip and keep her independent and living in her own home at age 89. To me, this is priceless. So let's take a look at a summary with all the pieces working together, because we need all the pieces working together. And let's not forget how important medication adherence is to successful outcomes. And this is a big piece right now. I'd like to give you my contact information and then walk you through navigating the nbha.org website to the patient materials. Let me do what I can to help you. I'll admit that I'll respond quicker to the AOL email address. I'm probably the only person left with an AOL email address, but I'll respond quicker to that one than the KP address. And the phone number is my cell phone. I'm very receptive to talking to you on the phone. If I don't answer the phone right away, I'll call you back just as soon as possible. Okay, let me walk you through the steps on the NBHA site and how to navigate to the tools. I also want to stress again that there's a wealth of information there on the site. Don't think you can just quickly scan through all of this. Go pour yourself a cup of coffee and plan to stay a while. And you'll have these slides, so you can go through these slides very easily on how to get to all of the tools that I've told you about. Start by going to the NBHA website address that I have on the slide. And then all you need to do is follow the green arrows with me. You'll need to create an account with your email address and password. It's free. They don't send you any spam email. You won't get on any catalog list. It's very easy to do this with the NBHA. Next screen, just click on See What's New under Webinars, Business Plans, and more tools you can use. If this screen does not pop up and it looks like this screen, go ahead and click on Tools and Resources. Once again, just follow the green arrows. The next screen, click on FLS Organizations and Resources. Go to the next screen, which is US, and that stands for United States, FLS Resources. And the next screen at the bottom of the page under Kaiser Permanente Healthy Bones Program, there's a link that says nbha.org, and it will have Kaiser Tools at the end of that link. Click on that website, and it will open up to the Kaiser Permanente site with our tools. You'll see all of our tools. At this point, click on what you'd like to open and look at. But keep in mind, each one of these links will open many documents. So these are actually folders. And plan on spending some time here, because when you open up one of these links, there'll be many, many, many documents inside these links. And then when you have time, go back and open up many of the other areas where there are other FLS programs and the tools that they have. Thank you so much for your time and attention. Now we have time for questions.
Yeah, this is Debbie. Just as a reminder, on your control panel, see the questions area. You can enter your questions in there, and we'd be happy to answer them. Okay. One question we have is, how many languages are the materials available in?
We have languages of the Spanish, Vietnamese, Chinese, and English.
Great. Let's see. Our next question is, how do the FLS differ in an open system than a closed system like Kaiser?
That's a good question. Probably the biggest difference is the coding. Debbie and I were just talking before the session started that our coding is different, and we're not as familiar with the coding inside our system as on the outside. The electronic medical records also is much easier within our system. Our communication as a result is easier within our system because of our electronic medical records. So things are done very quickly as far as communication. I think that makes a big difference. Those are probably the two things off the top of my head that I can think of. Our electronic medical records makes communication much easier, and our coding is different.
Great. So the next question we have is, what secrets do you have to get all level of docs actively engaged? What has worked for you to get them speaking out in the community?
To be honest, we have tried with our primary care providers to take it out of their hands and put it into the hands of our Healthy Bones care managers, which are our nurse practitioners and physician's assistants. We find that our primary care providers are extremely busy and often overwhelmed with other diseases that take up so much of their time with the patient, such as diabetes, heart disease, as examples. So oftentimes when they don't have to spend a lot of time with osteoporosis and our Healthy Bones care managers take over that job, they're very relieved. So oftentimes we try not to burden them with osteoporosis, and we take over all of that care, and that's a big relief to them. We're usually the ones that go out into the community as far as health fairs, conferences, and we're the ones that are giving the presentations. The same is true with our orthopedic department. Usually, oftentimes our Healthy Bones program is housed in an orthopedics department or a population care management department. So usually we try to be the ones to take over that entire program and that entire osteoporosis awareness management.
Great. So our next question is, have all these materials be run through our program to determine their level of readability? If so, what grade level are these documents?
Yes, we do have a health education department at a regional level, and we do gear our documents to a 5th grade level, and they were screened from a legal standpoint also. So yes, and that was our regional health education department.
Great, we just got another question. How many NPs and PAs does the Healthy Bone program have?
We currently have 14 medical centers, and we have at any given time usually around about 35 total nurse practitioner or PAs. And oftentimes it depends on just the medical center, how the economics of that medical center, how much money they will decide to put toward that program. So oftentimes they will have 1 or 2 Healthy Bones care managers for their program, but sometimes they will be part-time for that program. So in other words, if they're housed in a population care management program, possibly they're a full-time position, but maybe they're allocated part-time to the Healthy Bones care program and part-time to a hypertension care program. So it just depends on the medical center, their finances, how they are allocated to the Healthy Bones care program. So usually we run about 35 nurse practitioners and PAs for the entire program.
Okay, it looks like I have 2 follow-up questions to that. The first is, are your NP and PAs family practice trained, or are they trained in other specialties? And how do they increase their osteoporosis knowledge?
They come from all specialties. They're not specifically trained in family practice. We give them our own training in osteoporosis, and then they're ISCD certified. So they do have the ISCD, which is specific for clinical densitometry training.
Great.
But we do give them individual osteoporosis training for our program.
Great. For the 35 NP and PAs, what has been the ROI for their programs?
Remind me what ROI is.
I'm sorry. Return on investment.
Oh,
so
okay.
For the 35 NPs and PAs, what has been the return on investment for their programs?
So usually when we're introducing a program, and especially when we're trying to get financial backing from that individual medical center, what we look at is the hip fracture savings. So for our institutions, we spend $35,000 to $40,000 per hip fracture for those hip fracture costs. So usually we look at the savings for hip fractures, and usually that is our return on investment for their full-time salary.
Great. Our next question is, are we allowed to adapt Kaiser's print and electronic materials for local use?
Yes, we don't have copyright on those, so it's very easy just to copy and paste your institution over our tools, or you can use them as templates to create your own ideas.
Great. The next question is, what EMR system are you using?
We use Epic, and we have used this for quite a long time. There was a big learning curve when we first adopted this system, but it has worked very well for our institution.
Great, and Alyssa, we just have another question about getting a copy of the slides and the recording. So just to let everybody know, again, that the webinar will be posted on the Fracture Prevention Central website, as well as NBHA's YouTube channel. And all those who have registered for the webinar will also receive a copy of the slides in 4 days. And that'll be the same time for the recordings to be posted. Are there any other questions? If you have one, you can type it into the question section on the control panel. What insight could Kathy give regarding those that work in an open or private practice?
That's a very good question, since I've always worked in the closed system in Kaiser Permanente, but the feedback that I've gotten from people in the open system is communication. And it seems like even in our system, the communication between not only patients, but it seems like the communication between the providers and who you choose to be your champion, whether it's a physician champion or whether it's a nurse, whether you're using a nurse protocol or you're using a nurse practitioner or a physician's assistant, that communication method you choose is going to be so important. So whether you're emailing the physician, whether you're communicating somehow between the orthopedic doctor and the primary care doctor, or you're communicating from the hospital to the endocrinologist, whatever your method of communication, however you're making that mode of communication, somehow there has to be some way of making sure that that patient who has had a fracture or that patient who has had the low DEXA scan score, that communication to someone who is going to follow up with that patient is made, because it seems like so many people just fall through the cracks. They have a fracture or they have a low DEXA scan score and nothing happens. And so there needs to be an effective way of communicating with someone to take care of them. So what we have found with our program is that with our Healthy Bones Care Managers being the people accountable for them and getting them on treatment and taking care of them and making sure that there's a follow-up, that's where we found we have our success. With our electronic medical records, we accumulate lists of patients and they never fall through the cracks because they're continually on these lists and they don't go away until someone takes care of them. So I think what happens, and this probably happens more on the outside than it does in a closed system, is that these people just disappear once they have their fracture or their low DEXA scan score. So just establishing some type of communication, whether it's from your hospital to a primary care provider or the orthopedic practice to the endocrinologist, somehow establishing some type of system where these people don't fall through the cracks. And I think what we've seen nationwide is that oftentimes orthopedists don't want to take responsibility because they don't want to medically manage, and primary care doesn't want to take responsibility because they feel orthopedists are the bone people and they should take responsibility, and it becomes a vicious cycle. So I think someone needs to be accountable, and there needs to be an effective system. And there needs to be people who are really passionate, and champions are really the key, and that has worked for us.
Great. Next question is, do you have a medical director or a co-medical director? Have you seen either drive inclusion or exclusion in the program initiatives?
We have medical directors at each of our medical centers, but I think what is key for us is that at our regional level, we have physician champions we have a Healthy Bones core team, and we have physician champions within that core team. So we'll have at any given time 2 or 3 physician champions, and then we have a clinical consultant, and then I'm the education specialist. So we have always had an osteoporosis core team. The medical directors have always at each medical center been on board, but we've also been around for a long time. I think what probably sold everyone at the beginning was the economic savings. But to answer the question, yes, we do have medical directors, but we have physician champions who are the ones that are actually in charge of making decisions, and our medical directors are on board.
Great. I have a follow-up question. Follow up on the PCP question asked before. When we are just opening our clinic, how do we make sure that we are not stepping on any toes of those PCPs that do not want to care for their patients' osteoporosis?
So I'll maybe try and clarify the question. I'm thinking that some PCPs don't want someone handling their patients. And sometimes what we have done, let's say as an example, an endocrinologist has an osteoporosis patient that they would prefer us not to take care of. And we just honor that. We know who that endocrinologist is, and when we do the DEXA scan, we just send the results to them, and we let them handle that. So we just honor that. So I think that you just need to be aware of which physician that is and keep that in mind and let that physician handle their own patients.
Great. The next question is, does your program have operational goals? For example, time to ED to OR, etc., that shows positive outcomes?
Trying to understand the question. I think when we first started, we had many, many operational goals. I think now all these years later, most of those goals are incorporated into the program and are fairly routine. So the way everything we have is through our electronic medical records and incorporated into what we call at-risk database lists. So as an example, the emergency room creates lists of patients who have had fractures. The DEXA scan machine creates lists of patients with low DEXA scan scores. And these lists are refreshed daily and available to our Healthy Bones care managers so that they actually in real time have these patients available immediately so they can contact these patients. Because once they've broken a bone, if you wait for a month before you contact them, it's not as effective as contacting them the next day. Oftentimes, too, the Healthy Bones care manager can visit that patient while they're in the hospital after they've had their surgery for their hip fracture, and then that is very effective for that patient also. So some of those operational methods have already been incorporated into our program, but we've tracked all that progress and it's been very effective.
Great. We have another question. Do you have a sample of a letter or a pamphlet that you give to patients at discharge from hospital or ER for referral to the bone clinic?
We have lots of letters and brochures and handouts that we use, but we don't actually have a referral because our Healthy Bones care manager will call that patient. They'll have the DEXA scan appointment made for them through our system. So it's not actually a referral to something that is outside of our Kaiser system. So it's not actually a referral letter, but we have many letters and brochures and handouts that we have available in the tools that are on the NBHA site. But we don't have an outside referral type letter because everything is within our system.
Great. We have another question. What is your protocol for following up with patients who have been sent to a rehabilitation facility?
So the SNF, if it's something like a SNF, we have nurse practitioners, PAs that work within the SNF and geriatricians that work within the SNF. So it is the same type system. They will work with the patient within the SNF. We don't necessarily have an outside rehabilitation center. Everything is more within our own system, more of a closed system. But if there would be an outside, some type of outside place that they would go to, they would be ordered a DEXA scan. They would come back, have the DEXA scan. It would be the same workflow process where they would then go to see the Healthy Bones Care Manager immediately after their DEXA scan. If for some reason they were somewhere and they could not possibly have a DEXA scan, the visiting nurse practitioner or physician's assistant or geriatrician, when they visited them in that outside facility, then that process would be done during that visit.
Great. It looks like we have time for one more question. Let's see, has your Healthy Bone Care Manager ever hosted other NP or PAs who are looking to start their own FLS?
Yes, we have. We have had people come. In fact, someone came just a couple months ago from, I think, the Washington, D.C. area. And we have people come to one of our outside medical center clinics and observe and talk with one of our Healthy Bones Care Managers. So that can be arranged, yes. And you can just contact me.
Okay, wonderful. Well, thank you, Kathy. I want to thank everyone for joining us today. And just a couple of quick reminders. The webinar will be posted on the Fracture Prevention Central website, as well as a YouTube channel. As Kathy mentioned, you can feel free to reach out to her. I also wanted to mention that we can easily connect you with Kathy through the Fracture Prevention Central FLS one-on-one consult service. And if you go online to Fracture Prevention Central, you'll be able to see where there is a form and you can enter your name, your question, and then we can connect you, whether it's with Kathy or another FLX expert, to have your questions answered. So thank you, everyone, and we hope to see you next time on our next Fracture Prevention Central website. Have a great afternoon.
Thank you.